طيب، بسم الله والصلاة والسلام على رسول الله. التحية لجميع الحضور، ونتمنى إنه برنامجنا ده يستمر وما يتوقف، ما يكون في تلكؤ من الجانبين، من جانب الأساتذة ومن جانب الحضور من الترينيز.
السلام عربيته
لأنه
أخيرا.
لأنه مهم جدا جدا استمرارية التدريب في الظروف اللي بيمر بها بلدنا دي لحد ما تنخشح هذه الابتلاء بإذن الله. نرحب بالدكتور نادر الزين، وهو يعني أستاذ معروف، و he has been practicing in Sudan for the last few years. فرحب به في المحاضرة الثانية بتاعت السايكوباثولوجي. I'm sorry I was not available last 2 or 3 weeks. I was away. مرحب دكتور نادر.
جاب البيض ولا ما جابه؟
The floor is yours. البيض ما جابوه يا طارق، البيض ما جابوه.
سوري.
السلام عليكم.
هذا فتحية، كيف حالك؟
معلش والله كان ما كونكتد يعني من قبل بعافر فوق، طبعا احنا خبرتنا ضعيفة يا دوب الصلاة.
مرحبا بك ومرحبا بالجميع، نرحب بهم ثاني. الجو تفضل يا دكتور نادر. The floor is yours.
Thank you very much. شكرا دكتور عبد الغني. Today we'll talk here second part of a series of 4 lectures about field of psychopathology. First was last week. I can end an introduction to what is psychopathology, and we explained that it's the scientific exploration of abnormal mental state, and there are broadly speaking 3 types, which is descriptive, which describes the phenomena from an objective or subjective and an objective perspective. You've got also clinical psychopathology, which attempts to link symptoms together to come up with diagnostic criteria. And lastly, which is the experimental psychopathology, using linking certain symptoms with or syndromes with neurosciences. For an example, that manipulating dopamine receptors may give rise to certain psychiatric syndromes. You can manipulate these dopamine or serotonin receptors by using substances which such as stimulants like ketamine, which also can give rise to symptoms suggestive of psychosis or schizophrenia. So we also gave a historical overview of how classification symptoms have developed since the first modern classification system, which was conducted by Philippe Pinel, the French psychiatrist, neurologist, which was actually entitled The Philosophical Explanation of Diseases, or the Philosophical Classification of Diseases. And now we've mentioned this, that the study is always based on philosophical concepts of phenomenology and how to explain not just abnormal but normal human experiences, or we can quote it as the mind. And we have talked about that the mind is the function of the brain. I had I would like to thank the doctors. They have been in contact with me, and I had a few comments that I feel that will need to be addressed. One is that well, the talk was exclusively in English, and I had explained, and as Abdul Ghani and Yasir and I, if you had overheard our conversation, is that these symptoms are not only have been explained in English, and English has overtaken the field of psychiatry since the end of the Second World War, but prior to that, it was mainly focused on European school, i.e. French, started with French and then moved on to German school of thought. Hence, some of the symptoms are labeled in either Latin or in German. But as I said, more recently in English. However, I have not come across a lot of studies that were in Arabic that had explained phenomenology in Arabic terms. The first and last attempt that had been made was in the late 70s, when some of the symptoms had been translated into Arabic, and that has also created a lot of controversy, and because of the religious or well, it showed that unless you study from the bottom and take it to the top, translation might not be the way forward. There are areas that can be translated, but in particular when explaining the symptoms or phenomenon, you'd have to have a base of philosophical understanding of what is normal, and then you move from then to the abnormal. This will become very apparent when we talk about speech delusions and hallucinations in my next talk, inshallah. The second comment was about, I think a colleague of ours, I forgot her name. She said that we can diagnose schizophrenia by not resorting to one of the ICD or DSM. I forgot the name. And the person who asked me wanted me to elaborate as to, since we can, if we fulfill the criteria for schizophrenia, why do we have to go over all these symptoms? And it is a fair question. As I had mentioned in the previous talk, that yes, in order to fulfill the criteria for certain, let's say, schizophrenia, you need about 3, maybe 4 symptoms, right? But to know what is a symptom from a non-symptom, or how to ask the question, that takes more than just a tick box exercise. Second, I would recommend going through all these symptoms. One, as Dr. Abdul Ghani had just mentioned, being a trainee, you'd have to have breadth of knowledge. But also, if you look at it in terms of dual diagnosis, patients are entitled to have more than one diagnosis. And if I were to say, if you have a patient with autism, does that exclude them from having symptoms of schizophrenia? Of course not. People with autism probably have a slightly elevated risk of schizophrenia. And actually, autism was one of the terms that was used by Bleuler when he diagnosed, put the 4 A's for his diagnosis of schizophrenia. So how would you know that someone has a diagnosis of schizophrenia, autism, or how would you separate someone with a diagnosis of autism and schizophrenia? Unless you have gone thoroughly through and these symptoms overlap, as probably we might mention today, some of the symptoms of autism are varying now, certainly in human interactions and stereotypy movement. It is common in both disorders. So you might end up having to do more than 3 or 4 diagnoses for schizophrenia if you want to establish. And another example is and now that we are talking about schizophrenia, is the work of Van Os in Holland, where they are looking at schizophrenia from a prodromal, the prodromal syndrome leading to schizophrenia. We, in our current classifications, they do inform us about the symptoms of schizophrenia, but they are not well organized to give a prognostic to say whether this type of schizophrenia is severe. Is it severe form of schizophrenia? You might have it for in depression. You'd have mild, moderate, severe with or without psychosis, but that is not the case in schizophrenia. Our current diagnosis does not give any or it lacks not very solid foundation in its prognostic value. So that is my question, my answer to the comments. Any questions? Hello? Can everybody hear me?
سامعينك.
Any questions? There is chat. بعتذر يا جماعة.
ده ما عنده علاقة بالكويستشن.
Okay, but today, as I mentioned, we'll go quickly through the list for behavior, speech, behavior and mood. Okay, for the majority of cases, particularly in acute psychiatry, behavior and appearance and mood is probably what will dictate your decision as to whether the person will be admitted or not. As a trainee, you'd have to be making that decision. It also is a good field, a good recipe to come up with your differential diagnosis. And now as I mentioned, the more symptoms you collect, right, or the more thorough your examination is, the more likely you will come up with a solid list of differential diagnosis. However, bear in mind that in an emergency situation, you may have 1 or 2 hours with your patient, which does not give an overview, as these symptoms are likely to change either in their intensity or their presentation or in their quality throughout the course of the illness. Right? So, but it gives you an indication as to where you're heading towards. The first decision probably you would want to make as to whether the patient will need first something to calm them down if they're in state of hyper arousal, or if you were to decide actually to approach the patient or not, because your safety is very important. There is nothing to be gained if the on-call doctor has been assaulted and would go off on a sick note. So whether how you approach the person is highly dependent on their appearance and their behavior and their mood. Hence this. So how you describe this person, there are, when a patient comes in, there are various means. If you are to look into work of literature, the more common note is that the author will tell you or mention the height and weight of the patient. If you look at the police reports, a 6'5" Caucasian male. So these are actually how you would describe person. Their height and weight. You look at their age and gender. You will look at their arousal and grooming, hygiene. Then you would be looking at some distinctive features, mannerism, facial expression, and body language. Also, to note, probably manner and cooperation will include how prompt and so forth they will speak with you. So, but this is all based on work of literature, how you present your case, how, and for in an acute A&E emergency situation, on call, you and the patient who is hyper aroused or over aroused, you may not get to speak to the person, or more relevant, may not be safe for you to speak to the patient, but you can get a lot from how they behave and report that to the on-call either registrar or report it to the on-call consultant. So in cases of, we said that height and weight is important. The first observation, you look at their age and gender. That is significant. There are more, a person who is very tall or has slightly unusual features, that might indicate some hereditary issues that have to bear in mind. People who are overweight are more likely to be, well, I say this, but this also goes back to literature in what we used to call the Pickwickian. Mr. Pickwick was a character in Charles Dickens' novels. He looked like, I look Pickwickian. I have a bit stout, not very tall, round the middle. I have a good sized belly. So that is what's called a Pickwickian. And it is actually more likely that people who with Pickwickian, or in those days, they had would be diagnosed with bipolar disorders. I'm not saying I'm bipolar, but more likely to suffer from mood swings. Now, if we go to arousals, increased arousal is more associated with increase in motor activity, increase in speech, and what is significant, particularly for affective disorder, is distractibility, not exclusively, but in hyperactivity associated with bipolar, have a distractibility. Another level of high levels of arousal is what is called Bell's mania, or the delirious mania, or catatonic excitement. It is also associated with mania, but also frontal lobe syndrome. I forgot also to mention this because I had a chat with Yasser. He has his interest in catatonia. We will be having he published a few papers, one which I actually had on me about a case report. And thankfully, he is in contact with Dr. Francis, who actually was one of the authors or the creators, or who devised the Bush-Francis catatonia rating scale. I will send you the paperwork at the end of this talk. We'll send you the rating scale. Hello, Victor, here. Can you hear me?
Yes.
On the opposite of an increased level of arousal, there is a decreased level of arousal. And a decreased level of arousal, like with any physical problem, you would look at whether there's infections, metabolic, neurologic, vascular, functional, or iatrogenic. Iatrogenic means that the symptoms or the disorder is caused by medication or drug-induced. So a decreased level of arousal can be caused by, as you can imagine, by sedatives, hypnotics, alcohol. Stupor is mainly associated with brainstem infections and normal pressure hydrocephalus. Okay. So motor activity, we talk about hyperactivity, which is increase in the action. Hypoactivity is the reducing activity. Does anyone know, think there's any distinction between hyperactivity and agitation? Well, I have found a textbook that says that agitation is an increase in non-goal activities, non-goal-directed activities. So you can see that person is walking up and down, right? But hyperactivity means an increase in goal-directed activities. So let us say someone is opening, moving, and doing something, cooking, and also trying to go out, trying to change their clothes. So that is a goal-directed activity. But agitation is just is a non-goal-directed activities. Right? Disturbance in gait, probably associated with cerebellar disorders, metabolic stimulant. Sorry, that question again with ADHD. What about the level of motion activity? In hyperactive, it is a form of hyperactivity, but it is slightly incomplete. The person with attention deficit hyperactivity, as the term implies there is a hyperactivity. It is goal directed. However, the pace of it is usually faster and slightly doesn't be complete, which is also affective. So how would we differentiate between hyperactivity due to ADHD or hyperactivity that is associated with a bipolar disorder? Any suggestions? Hello? Well,
Associated features.
the associate, yes, دكتورة.
السلام عليكم دكتور نادر، كيف
عليكم
اخبارك؟ معك
السلام.
دكتورة نادر عز الدين.
ايوه.
اعتقد بالنسبه لل ADHD الهايبر اكتيفيتي، انت زي ما قلت الاجيتيشن بيكون نون جول دايركتد، هنا بيكون بالنسبه للهايبر اكتيفيتي العاديه بتكون جول دايركتد. بالنسبه للمانيا دايما بتكون الهايبر اكتيفيتي هي completing a task, cleaning, يعني بالنسبة اللي بعمل تايدي الحاجات بيكون دايما بيكون complete a task. أما بتاع ال ADHD as I know يعني he cannot complete a task، وبكون الكونسنتريشن يعني ما بيكون في لاك في الكونسنتريشن وبيكون في لاك في الاتنشن. فدي بتخليه انه دايما بيكون يعني الحاجة بتكون not complete و untidy وكده. ده حسب فهمي لها.
Okay, good. Any comment or anything further ممكن to differentiate
ممكن اضيف
between...
حاجه يا نادر؟ ساره بليل معاك.
سارة ازيك؟
طبعا يا جماعه، نادر انا ونادر دفعه احنا اولاد دفعه مع بعض في الكليه، ف we go back a long way. بس
لا ما
حبيت
لونج،
يعني
ما لونج، ما في داعي اللونج.
طيب انا بس حبيت يعني الاجيتيشن فيه طبعا a sense of discomfort عكس الهايبر اكتيفيتي العاديه. يعني it's a very
أيوة.
uncomfortable sense of frustration, anger, restlessness, extreme anxiety. فالاجيتيشن
أيوة.
is not a happy experience. ما زي الهايبر اكتيفيتي بتاعت الاي دي اتش دي اللي هو احتمال يكون طبعا غير انها بيربسفول ولا كده، لكن ما نسال زول بيكون uncomfortable ولا distressed بها، على عكس الاجيتيشن يعني.
That is excellent. يعني like we said في last إنه in psychiatry our diagnosis are more syndromal، يعني group of symptoms coming together and in different aspects. يعني very rarely يكون في aspect واحد، فبنكون في agitation اللي بيكون associated مع أو الهايبر activity اللي associated مع bipolar هو بيكون زي النيم implies إنه فيه a strong affective component. وكل ما كان البرزنتيشن الهايبر اكتيفيتي اكتر، كل ما كان الليفل اوف affective component is stronger. In the hyperactivity في ال ADHD less so. يعني انه is that how I understood it? Hello?
ايوه نعم، ايوه نعم،
ايوه تفضل دكتوره، تفضلي ساره.
ايوه نعم exactly as you said. يعني اللي هو الحته الافكتيف الافكت اسبكت حقها بتاعت الريليشن للاحساس حق الزول ذاته. يعني الزول بيكون agitated بيكون very distressed، ما بكون قادر تريلاكس، في inner sense of restlessness و physical sense of restlessness. فانت بتكون شايفه لكن هو ذاته ما settled. الزول عنده hyperactivity is different. انتوا لسه ناس لسه ما مشيتوا للسبيتش وكده. يعني almost different زي قصه لما نقول لك يعني الزول يكون pressure of speech ولا حاصل له انه بس انه speaking fast. ف almost كده. يعني انا بس عايزه امثلها بالحاجه دي، لان يعني الزول speaking fast مثلا مختلف من الزول pressure of speech. هنا agitation ما زي hyperactive at all. فهم في حاجات قريبه من بعض لكن they're completely different.
Which leads us nicely to akathisia. كويس. Probably most of you are aware of, in akathisia is a side effect of psychotropic medication, خاصة الانتي-psychotics, or more likely إنه يكون الانتي-psychotics the first generation, more commonly يعني الهالوبيridol, which we use to sedate patients, and there is a likelihood that once you give the patient an injection to calm them down, that you find that actually they are pacing up and down, or they're not able to sit still. There is an inner sense that they want to move, or so you'd have to appreciate that symptoms. It is a side effect of your medication to treat hyperactivity. So it is important to differentiate between the hyperactivity or the agitation that is functional or caused as a symptom of the disorder rather than iatrogenic or side effect. Okay. Well, where are we? Yep. We were going to talk about speech next time. There is also the issue of catatonia, and as I mentioned, we will have a talk. I think it's a Friday towards the end of the month. Professor Francis will give us a talk. He is one of the psychiatrists in collaboration to create the Bush-Francis catatonia rating scale. We were just talking with Dr. Yasser about catatonia. He has a very interesting point of view about cause or... Hello? Sorry, I can't hear you. Hello? So,
الميكروفون كان فاتح بس ليوزر.
other symptoms of motor symptoms of psychiatric disorder, we were just speaking out to Dr. Abdelghani, is what is called negativism. Has anyone come of it is said to be common in schizophrenia. Probably it's more common in biological or neurological disorders, but they do come up in... What is significant about psychopathology also is that they are very common MCQ questions. So you do need to know your catalepsies from your stereotype movement, which is a repetition of mundane actions. So stereotypy would be, let's say, in children. That is probably more common in children, or children with learning difficulties when they flap their hands, right? That is stereotypy, as of versus what you call mannerisms. It's the way that a person expresses themselves. Let's say when the way they smoke their cigarettes, the way they keep putting on and off their eyeglasses. You also need to know about automatic obedience, and where you have two types, as I found here, that mitmachen, another German word, which is there is an automatic obedience, which goes with the waxy flexibility, but also there is mild resistance in mitmachen, but in mitgehen, it responds to the slightest touch. So if you were to put your finger on someone's arm, it will float, it will move. Then you have the term appitendency, which is a form of ambivalence. The person starts to initiate an action but stops. So these are the actions or motor symptoms. I have sent you the fish psychopathology. That would be sufficient, but also copies of the symptoms in the mind. That would also be more than sufficient. Now, how would you describe mood? Well, mood can be described in various ways. We can look at or affect. What is anyone with any view about what's the difference between mood and affect? Hello? Anyone can tell me the difference between what is a mood and what is an affect, or what's the difference between them?
يلا يا شباب يلا يا شباب
عايزين contribution من الترينيز يا جماعة.
ده بتاع R1 يا اخواننا، ده بتاع ميديكال ستودنت. والله السؤال ده ما R1 كمان، ده سؤال للميديكال ستودنتس. My students used to answer this question. 4th year medical students. لازم يكون في interaction يا اخواننا. انا عارف كلكم عارفين. يلا واحد.
Okay, whilst you think about it, كويس. And just broadly speaking, we won't go into all the disturbance lane.
السلام عليكم. أنا إيمان عمر. I'm R2. I think mood is subjectively as you ask the patient and in his words how he describe it, and the affect is objectively how I see the patient with his facial expressions maybe, and how I describe it.
السلام عليكم. أنا فاطمة محمد صالح. معظم الكتب أو الكتب اللي قريت عليها تقول فرق بين الافكت والمود زي الفرق بين الكلايمت والويذر. الافكت إنها هي في اللحظة الحالية، بينما المود يعني more extended. يعني مثلا ممكن أنا أقول الزول ده خلال اليوم كامل يعني لو مود، فده حقول لو مود، لكن في اللحظة الحالية اللي أنا بشوفه فيها اللي هي الأفكت العاطفة، يعني العاطفة غير المزاج، إنه العاطفة الحالية اللي هي الأفكت. فده تفسيري أو حسب القريت.
ألو.
ايوه شكرا للمشاركات دي، شكرا. عايزين انكم تشاركوا لو ما في مشاركة
السلام
ثانية.
عليكم.
طيب تفضل.
ممكن أشارك. يعني بالنسبة للمود هو بيكون دايما persistent، هو emotional state وبتكون persistent more than الأفكت. الأفكت دايما بيكون يعني short duration و reactive أكثر من المود.
شكرا. 3 مشاركات كفاية. نادر the floor is back to you. تفضل. نادر ما معانا ولا شنو يا ياسر؟
معانا لكن ميوت.
خلاص نادر it's back to you.
نادر you can unmute yourself.
take over مع نادر. في 3 مشاركات ويكومنت على ال3 مشاركات.
ما اعرف اذا عنده مشكله في الشبكه ولا حصل شنو.
عاد لو في الامارات في مشكله في الشبكه دي تكون عوجه.
خليني ارسل له. اختفى هو ذاته، فاحتمال يكون عندي مشكله في الشبكه وداخل تاني. ارسل له انا.
انا ما شايفه في الزوم.
اختفى هسه، فبشكله طلع وراجع تاني. هرسل له.
طيب لحد ما نادر يجي نستغل الفرصه دي شباب وشابات. دائما والله انا بقول انه الانتراكشن is more than one sided message. يعني لما يكون interactive session الناس
Hello.
بتستفيد.
Hello.
ايوه نادر رجعت؟ اوكي
Hello.
خلاص نادر. يس سامعينك واصل. انت سمعت الثلاثه مشاركات بتاعت الدكتورات؟
ايوه شكرا.
يلا
بس
خلاص
my
back
last
to you.
comment انه how to look at changes in variability in mood. You would look at the intensity, كويس, the quality, the variability of the mood. يعني intense, is it intense? Is it blunted? Is it a form of dysphoria? Is it low? You look at the quality, كويس. Variability, does it change? How much it change? How appropriate it is. لو انتوا if you are aware انه في الديسكريبشن بتاع congruent, mood congruent or mood incongruent. وفي another one, the last but not least, the recognition. Does the person recognize that there is something wrong with them? Can they explain? في syndrome بتاع alexithymia, people who cannot yes who will find it difficult or who do not recognize that or cannot explain their feelings. That's called alexithymia. Not to worry about them. And I just wanted to give you an overview of these syndromes or symptoms. And probably because it also, I'm focusing on the next lecture, which will be on disturbance of speech and thought and perception. But I would hope that people would do some groundwork for that, so it will become more of a discussion rather than just a one-sided explanation of the symptoms. Okay. Any questions? Yeah, it's 55 minutes now. Any questions?
السلام عليكم دكتور نادر.
اهلا بك.
انا بس عندي مشاركه، يعني انه البيشنت بتاع في كاتاتونيا يعني حصل بس في خلال during الروتيشن كله. شفت البيشنت اول ايام ما بس البيشنت ده هو كان بيقوم بيقف في الشمس، بيكون في abnormal posture، وبعدين اللي هو لما تجي مثلا تلمس يده او كده بيقوم بيغير البوزيشن يعني even weirder position. وكان ويديagnosed him with catatonic schizophrenia. يمكن البيشنت الوحيد اللي مر عليه ثاني ما بنساه اصلا. بعدين كان برضه شنو يعني انا بس المتماخن والمتماخن والجهن ديل ما بعرف الفرق بينهم الى الان. لكن هو اللي هو شنو، هو كان في حبه مقاومه كده، لما تهبج مثلا يده بيقوم بينزلها تحت بعدين ثاني بيرفعها لفوق. فده اصلا ما بنساه، وكان في اتجاه الماحي. دي الكيس الوحيده اللي مرت عليه بتاعت كاتاتونيا يعني كده واضحه، وواقف في الشمس وفي ابنورمال بوتشر. يعني حبيت اشاركها مع الشباب يعني.
في الاوتوماتيك اوبيدينس انه لما يكون في resistance ده most likely انه متماكن. متجيهن is all it needs is a touch. يعني وحتى there are reports, case reports, you don't, if you move your finger, كويس, beside their arm, the arm will move. So mitmachen is mild automatic obedience with mild resistance. Mitgihan is an automatic obedience with slightest of touches, right? Or what is called magnetic obedience, right? As we were talking prior to people have joined, and I'm not sure if you have heard the discussion, Dr. Yasser and Dr. Abdul Ghani and myself, about these symptoms. There are majority of symptoms, unless you look for them, you probably may not find. Now, up to 50-60% of patients with different forms of schizophrenia, not just catatonic schizophrenia, but all types of schizophrenia, would have some form of motor symptoms. And that, even in affective disorders, probably up to 80%. Hyperactivity is a motor symptom. In patients with bipolar, it is probably up to 2/3 or 3/4 of the patients. In depression, anhedonia, lack of energy, inertia is probably common. So, and that is a motor symptom. So the question would be, what is a motor symptom? And if you do not make it a habit of yours to record these symptoms or to look for them, you would skip them. So I'm sure that it's likely that the patient you have mentioned, Dr. Tariq, had a form of catatonia, but let's not forget that the majority of people with mental health problems have one form or another of motor problem. And let's not also forget that majority of people with psychiatric problems have also physical problems. And physical problems are likely to have motor presentation. And what you don't want to do is mix a neurologically or organic, a physical or motor disorder or motor symptom caused by a physical problem. You miss that for a psychiatric one, assuming that it's a psychiatric representation. So all these symptoms that have been I've mentioned, they can also present as they do present in people with physical problems, neurological problems, problems to do with the CNS. So that is what, if there's a message from the presentation today, that would be it, that you have to look for them, not just because of mixing a physical problem with a psychiatric problem, but the person may have more than one psychiatric problem, such as autism and OCD. Stereotype is a very common in people with autistic spectrum disorders, but also 2/3 of them have a diagnosis of OCD. The degree might vary, but they do have OCD, and you don't want to miss that. Okay. Hello.
شكرا نادر. It was very very interesting presentation. في أي زول عنده سؤال before we come to a conclusion؟
سار رافع يده.
تفضل.
عايزه بس تو كومنت حاجه. اول حاجه شكرا جزيلا على البرزنتيشن يا نادر. ثانك يو فيري ماتش. لكن الكومنت حقتي للترينيز صراحه، السايكوباثولوجي والفينومينولوجي ده العظم حق السايكايتري. يعني مهم انتوا لما تيجي تحضروا التوكس حقت السيمتومز اوف ذا مايند دي تكونوا انتوا قريتوا الحاجات دي قبل الليكشر دي، عشان الليكشر تكون مور فيها استيضاح والناس تسال من الحاجات اللي ما قدرت تفهمها. الحكايه دي مهمه شديده يا جماعه. يعني احنا مثلا هو فلان شغال في انجلترا، عادي العيان بيجي بيقول لنا والله عندي مانيا، لكن مانيا هو فهمه ده حاجه ما لها اي علاقه بالمانيا حاجتنا في الفينومينولوجي والسايكوباثولوجي. فدايما السؤال بيكون انت عند الاعراض شنو؟ قصدك شنو؟ فانت ما بتقدر تعرف الاعراض لو انت ما حتقدر تسال من حاجه لو انت ما عارف هي اصلا هي شنو. وات ار يو لوكينج فور؟ فعشان كده حكايه الزول يعرف السايكوباثولوجي دي well is really important. فاتمنى انكم قبل المحاضره الجايه الناس تقرا اصلا. يعني حسب المره الجايه افتكر حتكون عن المود مش كده والثوتس ولا شنو والبرسبشنز.
المرة الجاية إن شاء الله حتكون عن السبيتش والثوت والبرسبشن.
ما perception. مهم جدا تعرفوا البرسبشنز دي. مثلا زول يقول لك انا بسمع اصوات، احتمالك ادخل تكون ما اوديتر هالوسينيشنز، ما لها اي علاقه تكون بالاوديتر هالوسينيشنز. يعني الناس بتقول حاجات مره ما هي اكزاكتلي السيمتوم. فانت عشان تسال التفاصيل حقت السيمتوم عشان تشخص تشخيص سليم لازم تكون انت عارف انسايد اوت السيمتوم هي شنو والاعراض هي شنو. في فرق زي ما حسيت تكلمت عن الاوتيزم من الاو سي دي مثلا، من الاو سي دي بتحصل مع السايكوزيس، في حاجات كلها مختلفه، فكل واحده عندها الكرايتيريا حقتها. فيا ريت يعني بس الترينيز كلكم اقروا السبيتش واقروا الثوتس والبرسبشن ابنورماليتيز قبل المحاضره الجايه عشان يكون مور تستفيدوا انكم تقدروا تسالوا لو في حاجه ما واضحه وحاجه الناس ما قدرت تفهمها. معلش بس دي الاديشن حقتي يعني.
دقيقة عبد الغني زي الحال.
تفضل يا فتحية. مرحبا.
أنا عايز أرجع للسؤال قبل بتاع نادر واللي هو حصلت فيه هنا إنه طلع وجاء ما كان واضح شوية اللي هو بتاع الأفكت والمود. أنا أفتكر حقه شوية يوضحوا تاني دكتوريني لأنه دائما هم كونفيوز كده بيكونوا بين الاثنين، والسيجنفيكانس بتاعتهم بتاعت المود شنو بتاعت الأفكت شنو. لو هو قال لي كلمتين ثلاثة كده يكون واضحات يعني.
طيب affect is the how or the current feeling place of the person. انت بقول لك the mood يعني الافكت زي the temperature، لكن the mood is what the season is. كويس. that is one explanation. يعني انه لو دي كان مقاربة انه الافكت هي الحاجة اللي حاسبها دلوقتي، انه المود دي الصفة الغالبة. لكن to be more actually specific, the term mood has been superseded by the term affect. احنا less so بنستخدم mood disorders now. Now we are using the term bipolar affective disorder, affective disorders, less so but we do explain how the person presents in, they have a gloomy mood. We don't say they have a gloomy affect, they're likely to have a gloomy mood. With but in a way here it's not trying to say in semantics, but there is a trend moving away from the term mood disorders into using the term affect to encompass all the symptoms or the disorders relating to mood and affect. كويس. يعني if you look at symptoms that زمان عندك الديسثايميا و persistent mood, persistent depressive state or persistent depressive disorder, probably the one that's remaining هي السايكلوثاميا. لكن the term mood seems to be overshadowed now by the term mood is overshadowed by the term affect. If that explains it.
شكرا
Okay.
نادر. افتكر
Thank you.
شكرا فتحية في انك you raised this question again.
السلام
زي ما
عليكم.
قال نادر، الناس حسي يعني almost خلت الافكت حقيقة. في اغلب السكولز بيقولوا المود بس، والمود بعدين ممكن يكون اوبجكتيف وسبجكتيف، ما زي ما قالت بنتنا قالت المود بس سبجكتيف. نو، في السبجكتيف مود والاوبجكتيف. المهم المود سستين زي ما قال نادر. يس.
ايوه في سوري في ار ام انه المود is a persistent feeling.
يس.
It's persistent. Affect is a transient.
صح.
كويس.
طيب.
لكن ايهم اهتديتم يعني لو مشيت بناس سيم او فيش كويسه اللي هم لسه in probably UK they might still be using the mood more commonly the term or لكن more international. I can't remember when Greta can the change between the mood and affect and how the term affect has taken over from لأنه حتى في ده يمكن الكتب taking a more psychiatric، لكن لما تمشي ل psychologically minded they refer to them as emotions. كويس. ف as long as انك you're aware there is a subtle difference، لكن you're not going to describe persistent mood disorders or bipolar mood disorders. You would say bipolar affective disorder.
مرة بي موقف بس يعني هحكي يمكن يعني الناس تتذكر به الحاجات دي يعني طريف شوية. أنا كنت تريني وبعدين بشوف في العيانة وبتتكلم عن إنها very depressed و very low، وبعدين حتى بتدعى بإنها تكون من السرير ولا تستحمى ولا حتى تتسوق يعني. فهي بعد ما سبت تتكلم كده قلت لها كده الحاجة المستغربة إنك حاسة أنت قاعدة قدامي فول ميك اب، أحمر شفايف والحواجبين والوش يعني ده زول مجتهد في نفسه اجتهاد شديد يعني ما ماشي الكلام اللي بتقولي فيه ده مع الحاصل. فطبعا هو دي حاجه الزمن ده. قلت لي يا دكتوره انا عامله بوتوكس وعامله تاتو ميك اب، ف it's not always easy يبقى الزول تتكلم بس من شكل الزول يعني الحاجات دي كلها بيرمننت يعني ما بتروح. فعملها هي طولت فما لها علاقه اتول بالمود اللي هي مود يعني في اللحظه ديك يعني شكل الحواجبين يعني زي لما يكون ديبرشن مثلا الحواجب بتكون معقوده شويه، بيكون الماوث مثلا بتكون تاند، لو الملامح بتكون حاجه الديبرشن ظاهره. ما كان في اي ملامح ديبرشن طبعا.
طلعتي ما حريفه يا ساره
اطلاقا بعد ذاك تعلمت لكن
نحن غاية البوتكس دي ذاتها ما عارفينها شنو، لكن مشيناها بوتكس
لا
وما
نحن
بوتكس.
نعرفها دي.
انت بتعرفوها. طيب
البوتوكس البوتيلاينم توكسين ده اللي هو الوشوش كلها شايفينها يوثفول وصغيره وما في اي طبعا اكسبريشنز ولا تقاعيد يعني.
حقنينها بحاجه يعني بقت منفخه
حقنينها
كده
بالبوتيلاينم توكسين دي فبيعمل
بس
زي
خلاص.
الغش
التجاري
في
لا
سؤال
ليش سمح ماله؟
في سؤال
كويس. الغش
كثير من
التجاري.
الافاق.
معليش قبل سؤال افاقي يعني نحن من انا تريني والله عشان ما يحصل الكونفيوجن.
السلام عليكم.
من ما نحن ترينيز قالوا لنا انسوا الافكت وقولوا السبجكتيف اند الاوبجكتيف مود. الكلام ده قبل 100 سنه قالوا لنا
كده سهل كده بيبقى سهل.
ايوه بس السبجكتيف مود والاوبجكتيف مود اصلا في المينتال ستيت اكزامينيشن قال لنا ما تقول افكت. طبعا كل مدرسه عندها راي، لكن بس الناس تعرف الديفرنس، والديفرنس حتى يوضحوا لكم نادر بكل وضوح. يس واصلوا السؤال.
السلام عليكم. عايز أسأل دكتور نادر عن الفاريابيليتي اوف ذا مود، بتفرق كيف في الدياجنوزز وبتكون في يوم مثلا او في اسبوع او في شهر؟ بتكون كيف؟
هسه انا كان تعليقي
هاي
دكتور سارة انه في الحاجه اللي كنت بتذكرها في حاجه اسمها incontinence بتاع الافكت، انه كل الافكتس بتطلع في وقت واحد، يضحك ويبكي وما كويس. اسمها ودي كانت في البيرسوناليتي ديس اوردرز، وفي حاجه سيربيلو بونتاينال.
سودوبالبر بلسي.
كويس
سودوبالبر بلسي.
كويس. بالضبط كده. بالنسبه للفاريشن، انت عندك طبعا الباي بولر. كويس. دي في المانيا انه تساتسفاي 1 ويك، وعندك للهايبومانيا 4 days. بعد ده في الدايجنوزز بتاع الرابيد سايكلينج والالترا رابيد. كويس. الالترا الرابيد سايكلينج I think انه 2 mood swings per week. الالترا رابيد ديل 4 ولا 2 mood swings per day. كويس. Are you familiar with the diagnosis بتاع rapid cycling affective
2 or
disorder؟
4
I met
Four.
2 patients.
4
4 مش كده؟ 4 per day.
4 in a year.
4 in the أو 4 per year ده الرابid cycling، وال 4 وفي per day الرابid ultra rapid. I'm not sure. أنا ما أخترع عليه. كويس. لكن أنا I am aware إنه في الدايجنوز بتاع الرابid cycling والالترا رابيد. كويس. لكن how is that لما يكونوا 4 per year, how is that different from a bipolar? يعني هي زي اعتقد انها subsection from bipolar disorder. Although I have to say انه still questionable انه whether these rapid or ultra rapid, لأن it's probably exclusively diagnosed in females. Ways, and whether it can be separated from personality disorders. Ways, but that we maybe Victoria, you can look it up and tell us about it. دي منو سألني أو سألتني؟
آفاق إبراهيم.
أهلا
آفاق
دكتورة.
إبراهيم.
أهلا دكتورة. معلش.
الله يسلمك.
يعني في subsection بتاع affective disorder في الرابid cycling والultra rapid cycling. إنه depends on how many times it occurs within short period. كويس. لكن how frequent أنا I can't really say for certain unless إنه ياسر وسارة وعبد الغني they can help me. قلت لك إنه أنا ما متأكد في sub section of bipolar affective disorder اسمه بيقول لها rapid cycling affective disorder, وفي ultra rapid cycling affective disorders. How frequent cycles per and for how long a duration, I am not 100% sure. لو واحد من الزملاء أو الزميلات.
ايوه ياسر. يا نادر. الرابid 4 or more episodes per year, then you can diagnose rapid cycling 4 or more. ultra rapid دي honestly ما سمعت بها. ultra rapid.
اوكي.
ممكن أشارك؟
ايوه تفضل.
طيب أنا دكتورة نازك R2 عرب بورد. أنا
أيوة.
على حسب فهمته من كلام الدكتورة إنه هي مثلا البيشنت جاني من المود عنده related mood مثلا، فأنا ياخد كم يوم عشان أنا to help me in diagnose الكيس. بالنسبة للهايبومانيا it's 4 days. It's 4 days, 3 to 4 days enough. Yes. المانيا it's a week to diagnose المانيا. اللو mood it's 2 weeks to diagnose depression, and the anxious mood or anxiety is 6 months. to diagnose generalized anxiety. ده لو كنت أنا يعني جاوبتها بطريقة صحيحة.
هي دكتورة آفاق، أنت سؤالك كان عن
أنا سؤالي كان عن الديفرنشيال أكتر من إنه يكون عن الديوريشن، يعني إنه هي كم ويك أو كده. ف فأسي كان قلت إنه هي في البرسوناليتي، في المود الافكتيف ديس اوردرز. يعني
أسألين السؤال من أول تاني. سوري،
كنت عايز أعرف الكونسبت، يعني إنه الكونسبت بتاع الفاريشن أصلا إنه هو بيفرق كيف ممكن يكون بيظهر في شنو في الدياجنوزيس أكتر من إنه يكون في الديوريشن يعني سبيسيفيكلي.
لا، المود كويس. المود ما عندك زي ما قلت لك، أنت عندك increase كويس في increase وديكريز كويس. الانكريز ده مثلا it varies from واحد يكون irritable كويس، انه انسان مقلق وكده ليه ريج ده يكون عصبي وبيكورك وكده. وفي اللو مود او الديسفوريا، انه انسان حزنان وما مبسوط، الى انه يكون severely depressed، او حتى ممكن يكون catatonic mute. كويس. The symptom of a mood on its own كويس ما كفاية عشان تشخص لك. يعني ممكن الحاجات دي تحصل في mood disorder, anxiety disorder، ممكن bipolar affective disorders، ممكن في schizophrenia بتلاقي ناس خاصة بالbrief psychotic episode or acute psychosis. كويس، بتلقى فيه an affective component هنا يعني. فهي في حد ذاتها كويس السيمتوم هو بتاعت المود ما في النمو يعني ما بتشير، لكن وعندك البوست بارتم وكده. فلو سمعت رجعت للبرزنتيشن اللي فات، انا حاولت اقول انه in psychiatry in particular a symptom on its own may not indicate a disorder. يعني انت you have to take it within the context بتاع المينينج بتاع الشخص. and that is what is psychopathology. Psychopathology هو انك see how to describe a symptom, how to relate a symptom to other symptoms to create a psychiatric diagnosis, or انك to experimental انه السيمتوم ده you relate it للنيوروساينسز. يعني انه مثلا زي الكاتاتونيا بقول لك انه more related لل D2 dopamine 2 system وكده، لكن برضو which is not exactly true، يعني لانه even في السيروتونين انت بتكون عندك سيروتونين سيندروم، وال ال NMS فيها كاتاتونيا، فيها موتور سيمتومز. ف in a way يعني السيمتوم واحدة on its own ما بتعني لك انه الشخص مريض يعني، لكن تاخديها within the context بتاع within معاه other associated symptoms، معاه الbehavior والاttitude والthoughts والspeech والperception والcognition.
شكرا نادر، شكرا
يا بس شكرا يا بس.
وافتكر 20 minutes beyond our time، وياسر منبه